You guys do all of this whilst also carrying a debt of anywhere between 50 to 90,000 pounds coming out of doctor degree.
An hour break, which is my lunchtime break, I'm usually either doing home visit, working through prescription, working through blood test results.
That's your lunch break.
We're working ourselves to the bone. I'm very, very hesitant to send people down to A&E unless I really, really have to.
NHS is not short-staffed. NHS is short-staffed of the people it needs. But then you see 300 to 400,000 managers.
Goodness.
My guest today is Dr. Krishni Ratnam. Dr. Ratnam completed her medical degree at Bath and London School of Medicine and Dentistry and is currently working as a locum GP with aspirations to build an exciting portfolio career. Not only does she bring a wealth of experience in research and medical writing, but she's also a talented writer, fitness enthusiast, and a prolific dancer. On a personal note, I've had the privilege of working with Dr. Krishni on an infectious diseases ward where we were part of the same multidisciplinary team caring for chronic infections and HIV patients with AIDS-defining illnesses. I've seen firsthand her dedication, passion for patient care, and how she thrives as a fantastic team player. Krishni, welcome to Dose of Health.
Thank you for having me.
This is your first time on a podcast, isn't it?
Absolutely. It's all a little bit overwhelming, but thank you for looking after me.
Oh, amazing. I'll give a little bit of a backstory, you know, like we worked together on a ward and then you rotated and you went off. And then I think we just lost contact. And a few weeks ago, we literally just bumped into the same gym.
I know.
I'm like, is that Krishni? I'm sure we worked together. And then we had this 15-minute chat about career, about life. And we were like, and I was like, you know what? Krishni will be a great person to interview on a podcast. And I asked you, and here we are.
Here we are indeed. We shall see what actually happens at the end of this. So
I'm sure it's going to be great, you know. So let's just start with the beginning, you know. How young were you when you decided that you wanted to be a doctor? Like how did you come about? You know, how did you become a doctor or choosing a career out of all the millions of careers you could have chosen?
Do you want the honest answer or
the
answer I gave at my medical school interview? I wanted to be a doctor since I came out of the womb. No, definitely not that.
The raw truth.
So the absolute raw truth. I accidentally found myself in entering into medical school.
Wow.
I still stand by this. I think at the age of 18, it's next to near impossible to actually come up with a career decision, especially a decision such as big as becoming a doctor. Because becoming a doctor in itself is very much a vocation. It really does become your life at the end of the day. And to make that big decision at the age of 18, I think it's almost a little bit unfair on my A-level students and people who are doing all sorts of studies at the moment. I think Abby, you understand where I'm coming from an Asian background. There is a certain element of you're expected to do certain careers and you're certainly poo-pooed away from other careers for sure. I remember telling my parents, because I grew up drawing a lot. I loved animations, particularly Disney animation. I remember going up to my parents very proudly and exclaiming, I'm going to be an animator. And my parents immediately laughed and said, absolutely not, you're going to become a doctor. But at the age of 18, I had no idea what I wanted to do. I did a huge variety of I'm going to repeat that. I did a huge variety of A-level, and my A-levels reflect that. I did 5 of them because, again, I had no idea what I wanted to do at the end of the day. And then my aunt, who is an obstetrician, suggested, perhaps, why don't you try for medicine? And at the time I thought there was no way I was going to get into medical school, but I thought, why don't I just give it a go? And then I ended up getting an offer at Barts in London, and here we are, as a result.
I can so relate to it, you know, because I think we're both millennials.
Yeah.
And growing up in a Asian parents' household, I think you had three options.
Yeah.
Doctor.
Yeah.
Engineer.
Yes.
And an accountant.
Yes. And sometimes lawyering if you're really, really lucky.
Yeah.
If you're really lucky.
Exactly. So actually, you know, it's so crazy because my parents actually gave me those three options as well. And out of those three, they wanted me to be a doctor. And I rebelled. I was like, there's no way I can be a doctor. And it's a long story, but long story short, they just said, okay, if you can't become doctor, just become a pharmacist.
Right.
And I was like, I think my problem was I knew what I didn't want to become, but I also didn't know what I wanted to become.
And again, I think that's really difficult to come up with ideas at the age of 18 because it
was so hard.
I mean, you have to think about your sphere of influence. You go to school, you have your teachers, you have your peers. I went to a grammar school, one of the top schools in the country. There was a huge impetus for a lot of the graduates to end up going to Oxford and Cambridge or become a doctor or go to LSE to become prolific economists, etc. And that's your only sphere of influence. And going to a grammar school, I grew up thinking education was ultimately first, above all else. And so you don't really get much of a chance to sort of go out of that bubble of influence that you have. And then where are your other points of, you know, influence? Your parents. And my mother's a doctor, my father's an engineer.
Yeah.
Typical Asian parents, aren't they? Typical upbringing. But I mean, I think that's ultimately you're kind of stuck in that sort of sphere, and therefore you don't know any better. And it's only, I dare say this, I think only after the age of maybe 25, perhaps when you leave university, you actually start to really question what the real world is actually about.
Yeah.
So, I mean, I don't regret to some extent going to medical school, but I think perhaps at the age of 18 I was a little bit naive in terms of knowing what I wanted to do.
That's a fair analysis. So talking about uni life then, you know, from what I researched, I found out that getting into medicine is also very competitive, and 1 in 2.5 applications actually get accepted. So only 60%, 60% is the rejection rate to get into medicine.
Yeah.
So you must have done very well to get in. And well, like, what was uni life like to study medicine? Was it like all work and no play, or was it a mixture? Like, what was it like?
I believe a lot of medics would agree with me when I say this. There was an element of work hard, play hard. Perhaps I play hard a little bit more than working hard. I kid you not. I think it's difficult for me to say how university life was perhaps compared to other degrees, because I think when you're in it, you sort of normalise what that level of work actually is. Certainly the volume of work that we had to do was a lot. There's a lot of rote memorising that you had to do, and that was simply part and package of actually learning medicine. Medicine is hugely vast. And I mean, I was reading this article by Andrew Elder back in the BMJ, and there's an argument that actually, in terms of the amount of knowledge that we're accumulating over the years, I believe it's like every week or so, our knowledge is doubling.
Wow.
And so there was actually an argument that perhaps medical school isn't even long enough to actually cover everything that we need to know in terms of basic sciences nowadays, which is actually insane.
Wow.
I mean, compared to my peers, I remember my peers who did not do medicine, they were doing various other degrees such as English. They would have reading week. Never heard of that in my life. I was very, very jealous. I was like, what is this reading week? I don't think they did much of reading anyway during that week anyway, as a result. So I'm not even sure what that actually entails, but I was very jealous of them growing up during university. But it was a lot of work. And I think a lot of medics, and myself, I think most people in healthcare, we tend to humble ourselves. We tend to downplay an awful lot of the work that we do. Yeah. But actually, a lot of what we do is actually a lot of hard work.
Absolutely.
And we just get on with it and we don't really brag about it. So I'll just leave it at that. I think it was a lot of work. I had a lot of fun. I've made friends who I will say to this day are lifelong friends who I will, exactly, my ride or dies, as it were. So in some ways I'm really grateful. Having done medical school, I certainly learnt a lot whilst I was in medical school. It was what it was.
Makes sense. I remember, I mean, I actually totally agree with it. You know, I think my pharmacy degree was incredibly tough as well. Getting in was just the beginning, you realize. And then, 4 years, it just gets tougher and tougher and tougher. And I think the fourth year was just the hardest. And once you do finish, you just realize, my God, that was a marathon. Like it was, it wasn't easy. And it required a lot of effort going in. But building up on that, like I remember when I first got the job to actually work as a pharmacist, my first day was just an absolute, panic. It was just, I did not know. I felt like an imposter. I didn't feel like I knew what I was doing. Do I even belong there? I was like, anytime a doctor is going to come in and ask me a question and they're going to be like, they're going to find out he knows nothing. And I was like,
I'm a fraud.
I'm an absolute fraud. Like, what do you remember? What was your first day like as a doctor on the wards and stuff?
Goodness. What are you trying to do? Relieve my trauma? There's a lot of PTSD in there. I think when I first started, I kind of went in with that. Don't get me wrong, I was terrified. I absolutely was terrified. I moved to a different area. It was the first time I lived outside of London. I went up to Norwich for my foundation year one year. I was starting on gastroenterology, which I believe is a commonplace sort of thing. A lot of F1s kind of dread doing gastroenterology because they're quite complicated patients, particularly on the hepatology side of things. I remember leaving medical school thinking, oh God, what did I learn? I don't know. I don't know. What? How did that happen? How did 5 years go so quickly? What was that? It just all went in a blink of an eye, actually. Which kind of goes back to, when you're working so hard, you just don't realise how much you're working at the same time. I remember on my first day pestering my poor registrar on the ward every single moment, like, oh goodness, how do I even prescribe paracetamol? Simple things like that. I would actually double check with the registrar that I was with or the SHO that I was with, getting into a mild panic if their blood pressure drops even a little bit. It was chaos. To put it lightly, I was lucky with another F1 who also had the similar sort of feeling. So between us, we would sort of panic share. Right. So we shared the trauma of it all.
Helping each other
out. So it was nice. It was a weird bonding exercise. I would say trauma bonding is probably the way I would describe it. But I think I went into F1 with the idea that actually I was expected not to know too much.
Right.
And I think I was very lucky in that I had a very supportive environment in that, as a foundation year one doctor, you're supposed to know what's wrong and what's right. You're not supposed to know what might be exactly what's going wrong, but you should be able to recognise what's wrong and then know what is okay, what can potentially wait, what can potentially be left for a little bit later.
Yeah.
So I think for me, going into foundation year one, I already had it in my head, okay, you're expected to be a safe doctor. That's the minimum. So long as you're safe, it's absolutely fine. I think the real panic for me actually started when I went up to foundation year two, because at that point, you've been a doctor for a year. You're kind of expected to know a little bit more.
Yeah. I mean, I've worked with so many FY1 doctors, and FY1 is like your first year as a doctor, and boy, do they work hard.
I know.
You know, clerking patients to prescribing medications to ward jobs, ordering scans, X-rays, writing discharge letter.
Absolutely.
And you know, like you guys do all of this whilst also carrying a debt of anywhere between 50 to 90,000 pounds coming out of doctor degree, and you do that for a job that pays you 14 to 15 pound an hour initially. So my question is, why the hell do you put yourself through something like this? Why would anyone want to do that?
I mean, full disclosure, I started foundation year 1 about 10 years ago. Oh, good Lord, I've been a doctor for 10 years. Thanks for bringing up that trauma about my age, Abhishek. Thanks.
Oh, God.
As long as I don't look it. So I was very lucky. I was in the last cohort where I had to pay £3,000 a year for university fees. And so I believe the cohort after me did have to pay the £9,000 per year fee, which is, I believe, it's extortionate.
It's crazy.
I mean, I think had I been facing the £9,000 per year fee that a lot of medics are now facing they're facing currently, I would really have second thoughts about going into medicine, because I would have to genuinely think, is it worth it?
Yeah.
So even though I was in my last year of being a registrar, I was about a few months away from CCTing, which is basically my certificate of completion of training to become a fully qualified GP. I completely supported the junior doctors' protests completely. I've seen how hard the F1s I worked with in my previous rotation when I was doing trauma and orthopedics as my last hospital rotation. And you talk about how hard foundation year 1 doctors were working in my time.
Yeah.
I think they work harder now.
Wow.
I really do.
Yeah.
I see the number of patients they have to look after compared to how much I had to look after.
Yeah.
The degree of responsibility which is placed on them.
Yeah.
The trauma of having to go through COVID as well.
God.
I mean, we were working during COVID, and you know, I had been a doctor at that point about 7 or 8 years, so I had a wealth of experience at that point, so I felt quite comfortable. But if I found it stressful, imagine the poor doctors who had just qualified, who barely were on the wards because of COVID, so they had to do a lot of rote learning through Zoom and through online lectures and things, and then to be plunked onto the ward in the middle of the biggest pandemic that we've ever faced.
God.
I really, really feel for our generation of junior doctors right now. So I felt that, because I remember my supervisor actually told me, why are you striking? You know, you're about to qualify. You're going to be one of us. You're going to be one of our senior doctors. But actually, we do have a level of, you know, responsibility to our juniors. They're going to be us at some point.
Yeah. Yeah.
You know, they're going to be taking over our jobs, and it is our responsibility to give some sort of pastoral care and actually support for their, you know, for what they deserve.
And if you're just strictly talking about the debt that you start with, so if you add the maintenance debt on top of the uni fee, it can go up to 80,000-90,000 pounds, and you have to pay interest on that debt.
Goodness.
So and if your starting salary is anywhere between 14, 15, 16 pounds an hour, you have to live in London as well. You have to pay your rent, you have to pay your bills, and you have to pay off this loan. Like, and a lot of people I have spoken to have just, you know, work extremely hard, and they have been doing it for like 10, 20, God knows how many years, and they're still paying off that debt. I think the system there is broken a bit, you know.
I mean,
and no wonder people are flying abroad
Yeah.
and actually leaving and having a brain drain that no one talks about.
I mean, Abhishek, I've only just CCT'd, but I know plenty of salaried GPs who've had to move out of London. So you've reached the end stage of training, and to become a GP, it takes about minimum 5 years, including foundation training and the 3 years of specialty training. There are GP couples I know who have actually had to leave London because they just can't afford it. They can't afford a house. They can't afford the rent. Yeah. It's just not tenable. Let's not even get started on how the GP market has completely dried up in terms of jobs as well.
Yeah.
And And it's just a travesty, just seeing the fact that, you know, there are patients who want to see GPs.
Right.
But then there are GPs who are actually out of work.
Out of work
as well. And this carries across over to... So when I was a foundation trainee, and I'd finished the foundation program, I was able to locum and basically be an F3, which is basically a year out before you go into any sort of specialty training.
Yeah.
I was lucky enough to do it for 2 years because there were jobs around. But as my understanding is, a lot of junior doctors just don't seem to have that ability at the moment because trusts are just not hiring doctors at the moment because they just can't afford to have doctors.
It's crazy. Like, why do you think that is? Like, because need is there,
I know.
right? The patients keep,
Absolutely.
Patients' biggest complaint is they can't see their doctors.
I know.
And you're saying that, you know, the doctors aren't being hired and there are so many doctors who don't have a job. Like, what exactly is going on, do you reckon?
I mean, do you want me to be blunt?
Yes, say it. Say it.
It's not enough money.
Yeah.
There's not enough will. I think the management powers that be don't really understand that the job that we actually do.
Yeah.
I think a lot of people who are non-clinicians see numbers as opposed to seeing human beings.
Yeah.
There's just not enough money.
Yeah.
And there needs to be more money to hire more clinicians. That means more pharmacists, more nurses. It needs to be more attractive.
Yeah.
I think there is a lack of attraction to the job working in the NHS at the moment.
Yeah.
Because, I mean, especially after COVID, I mean, how many nurses ended up leaving?
Yes.
You know, we were working on one particular ward together. And I think a number of the nurses did leave
They
afterwards.
had a mental breakdown.
Yeah.
A lot of them had a mental breakdown.
I mean, I remember when we were working on the wards and some of the nurses would come crying to me because it was too much.
Too much.
It was too much for them.
Yeah.
And I completely understand.
I mean, since we're all being blunt, you know what my theory is?
Yeah.
My theory is that NHS is not short-staffed. NHS is short-staffed of the people it needs.
I agree.
You know,
I agree.
So we keep hearing about, you know, NHS hires 1.2, 1.3 million people. Like, if you look into the people that they are hiring, you know, you're actually going to realize that the key workers that you've just said, pharmacists, nurses, doctors, you know, those are the people who are actually getting NHS running, who are actually doing the job for what general public really understands what NHS is. But then you see, now I don't really remember the figure, but there is about 300 to 400,000 managers.
Goodness.
That are hired within the NHS.
I wasn't aware of that.
Right? Like that number. And you know, we've all worked and we all know, like, you know, like the managers who has a manager, who has a manager, who has a manager, and they're just stuck in this loop of
the chain that forever goes.
The chain that forever goes. And then you wonder, like, you know, where is the money going? Right? Like, and it just makes you wonder that something is not right and something needs to be fixed. But turns out, like, the power that it just seems to be in the wrong hands, because, you know, if your doctor is not happy and your patients are not happy, then something's wrong with the system.
I believe it's a very Kafkaesque sort of scenario that we're actually facing at the moment with the NHS, and whether it's because the NHS is a huge monopoly in terms of employers, and whether that's part of the problem in itself, whether we've given too much power to managers who don't really understand what actually healthcare actually entails, being on the front line.
Yeah.
I mean, I read a rather interesting post on Reddit. I love Reddit.
Disclaimer, yeah.
But I mean, I don't necessarily blame managers or admin staff. We do need people like that to run the NHS. I wouldn't know the first thing about being a manager, for instance. But I did read something where I thought actually made a lot of sense. I think a lot of managers do work at about 100%.
Yeah.
For instance, you know, if we were going to compare percentages of how much people are working in terms of effort and things, I think there are lots of admin staff and managers who do a lot of work.
Yeah.
So it's not that they're not doing anything.
Yeah.
It's just that from my perspective, and I'm sure perhaps your perspective, what we end up doing on the front lines is we're doing 150,
yeah,
200%.
yeah.
And so that's where our sort of anger and perhaps aggro comes from, because we're working ourselves to the bone, whereas people are, you know, in those sort of, in the, you know, sort of the management admin sort of side of things, they're perhaps working at 100% capacity, but it looks like they're not doing as much because of how much more we're doing instead.
Makes sense.
Because I mean, I can speak for myself as a GP. The number of times I'm not even as a GP, even when I was a junior doctor, the number of times I stayed back an additional half an hour, sometimes an hour.
Oh, all the time.
And it's almost normalised.
Yeah.
I mean, I'm sure you've done the same thing as
all
well.
the time. 37 and a half hours a week? What? You know, are you joking? Like, you know, no key worker leaves on time in NHS.
I mean...
At least I don't know of any.
I mean, what is full time actually? And like, outside of the NHS, sort of full time work would be about 40 to 42 hours per week.
Yeah.
For us, it's 48 hours per week. Minimum.
Yeah.
Absolutely minimum. Yeah. And even going less than full time would be the equivalent of sort of going full time in any other job, which is absolutely insane. I mean, I've had this conversation with my friends who are non-medics, and it's actually insane the amount of work that we do, and work additionally on top as well.
Yeah.
Which, I mean, I'm going to talk about the GP current striking action.
Yes. Let's get to that.
I mean, the thing is, the GP striking, I mean, I think personally we don't go far enough, if I'm being really honest. Because what we're doing in terms of our strike is we're basically just working to our contract.
Right.
That's it.
Right.
That's all we're striking.
Right.
I think the general public don't actually understand how much additional work that we actually do. And so hearing Wes Streeting say something along the lines of, oh, we're punishing patients by striking. No, we're actually just doing the amount of work that we're contracted to do.
Such a gaslighting comment.
It is.
Yeah.
It is.
It's insane. I mean, I think we both agree that reform is needed. Definitely reform is needed. But like you mentioned that, I mean, you're a GP. Doctors can actually go down various paths. You can become a consultant, you can become a surgeon. I know doctors who go into pharma as well, and some become GP, and you chose to be a GP.
Yeah.
Why?
Good question. I think when it comes to career in medicine, there's a balance to be had between interest in that particular specialty, your personality type, and also what you ultimately want in life. Before I settled on general practice, I actually trained I was actually going to go down the route of accident and emergency. So I started with ACCS. And to keep the long story short, I looked at what my consultants were doing, and therefore my future as an A&E consultant, and I thought, goodness me, I don't want to go down that route. I saw the writing on the wall. I'm sure a lot of your viewers have seen all the news reports about the 4-hour waiting list and the 4-hour waiting times in A&E. It's not happening. Or people are in the corridors, and I lived that for the first few years of my training when I was doing A&E training. And I saw the writing on the wall, and I knew it was just going to get worse and worse. And we're seeing winter pressures in A&E in summer now.
God, yeah.
We're seeing it in summer now.
Yeah.
I know as a GP, I am very, very hesitant to send people down to A&E unless I really, really have to, which is such a shame, because it does have it has its place, but at the same time, in the back of my head, I'm thinking, is this patient even safe to go and wait there in the waiting room for 7 hours? Which is absolutely insanity. So for me, general practice was almost the lesser of the two evils. It allowed me a certain degree of autonomy, allowed me to have some control over potentially, if I become a partner, I could control the way the practice works. I have a bit more of a say, a little bit more of an easier lifestyle in some regards. I mean, it's not really 9 to 5. It's usually more 8 to 8. The reality of the job is actually more 8 to 8, but still I do have, I'm not doing night shifts and things. So at the time I thought, actually gives me a little bit more flexibility. I can finish a little bit sooner. And for the most part, I do enjoy my job when I get to do my job properly. Which is a whole other thing. But when I get to do my job properly and actually get to follow up patients and actually build up a relationship going forward, the whole cradle to grave thing, there is something quite special about that. And you don't get that with any other specialty, which is, it's quite nice.
Fair.
Sometimes.
I mean, you know, like, it's very easy to say that, you know, we work 8 to 8. But when you think about it, like, as a GP, I believe you have no idea who's going to come in with what problem.
Yeah.
And 8 to 8 is 12 hours and you have to be switched on from, you know, for 12 hours. And when you put it that way, it's no easy task, right? So what is a day in life of a GP looks like when you're actually at work?
Okay, so I say 8 to 8 because that's the way it works well for me. But I go in at 8 o'clock because there's usually some letter for me to action. There's usually some email from another consultant that I need to look at. And for me, that 1 hour before my clinic normally starts allows me to have the time and space to go through all my letters and my blood test results and things with a bit of peace of mind.
Right.
My clinic starts usually from 9 and then I go up till 1 o'clock, sometimes 12 o'clock, it depends. I work at 2 different practices. So one practice I work at has 15-minute appointments. The other practice I work at has 10-minute appointments.
Wow.
Yeah. And then during that 1 hour break, which is my lunchtime break, I'm usually either doing a home visit of some sort or working through prescriptions or working through blood test results.
That's your lunch break?
Oh, yeah. I mean, some...
Still working to your lunch?
I mean, we have no choice.
Yeah.
What else can you do?
Yeah.
I mean, some people, what they do is they end up taking those results back home. But for me, I'd rather just get it over and done with, especially if it's something urgent. You can't ignore it.
No.
So that's the poison I've picked rather than taking my work home with me. And sometimes that's not even enough, actually. So sometimes I don't even have a lunch. I'm usually at my desk working away and eating at the same time. And then lo and behold, I start my clinic at usually 2 or 3 o'clock, depending on the surgery that I'm at. See patients again for another 3 hours or so. And then usually that's my time for mopping up any other sort of admin that I need to do. So any referrals I need to action, any sort of queries I need to action. If there is and God forbid, if there's a medical emergency I have to deal with, say the asthmatic child who comes in and I can't turn them away because they're desaturating down to 88 and I can't abandon them. You know, God forbid something like that happens because that completely throws the whole clinic into chaos.
That's right.
And so when I say 8 to 8, it's because there's just so much.
Yeah.
It never ends.
Yeah.
Because I think the difference between being a general practitioner versus being in a hospital specialty, your patients are yours. You never really discharge them. There's always something to do.
Wow.
And at one of my other practices I work at, I work in the LTC side of things, which is the long-term condition side of things. So there's always projects, there's always audits, there's always quality improvement things to do as well. So that kind of digs into your time as well going forward.
Right.
So it's never ending.
Yeah. I
think that's the reality of being a GP. And I think what people don't really see is when they come into the GP's, you know, they come into my clinic room, they see the 10 minutes that they see me for. They don't see an awful lot of the background stuff that happens afterwards. I wish I had I have a patient who comes in, I see them and I think, okay, they need to be followed up by XY specialty, or they need this scan, or they need this medication. But what they don't see is after that 10 minutes that I've spoken to them and tried to figure out what's going on with them, I don't have a magic button to sort out everything.
Yeah.
I'll have to find the exact pro forma to use. I have to find the email to send this referral on to. I'll have to dig through their notes to figure out what exactly has already happened in the past, because the last thing I want to do is send a referral and actually 3 years ago they've been referred for that particular problem and it was been solved. There's an awful lot of stuff which happens beneath the surface,
and you have to be right every single time as well, right? I mean, talk about the pressure. But so I was full-time pharmacist working in the NHS, 16 years, and then I came out of full-time work. You know my story.
I do.
Of how, how...
Saved my skin many a time when I was working, believe me.
That's right, it was all me.
Steady on.
But I came out of the permanent side, and I've gone back to do gone back into the NHS, and I'm doing contract work like yourself as well. So why did you choose to come out of the full-time system and then go back in as a contract thing?
So I think less than full-time is something which a lot of medics do now.
Right.
I can't think of a single one of my friends who are doctors, GP or otherwise. I have a lot of friends who are anaesthetists and medics for some reason. They're all pretty much less than full-time. I went less than full-time for the first time during training in my last year of GP training for my own reasons, because I think working full-time in the NHS is too much.
Right.
I think what a lot of people don't really understand about working in healthcare is that you give so much of yourself away when you're working with patients. And I'm sure you feel the same way when you're a pharmacist. And every time you speak to somebody or have a consult with somebody, you're actually giving away a little bit of yourself each time.
100%.
And that's only sustainable to a certain point.
Yeah.
And there's a point where you need to start filling your own cup, which is why, absolutely. And I think it is important. I think as people who work in healthcare, we're deeply empathetic. We want to help people.
Right.
But we're often the worst people to look after ourselves.
Right. 100%.
It certainly took a lot of other people to tell me, actually, perhaps you need to go take a little bit of a step back. A lot of encouragement. And I really recommend, seeking, if anybody who's watching this, who's in healthcare, who might be on the brink of burnout, seek help. Seek help from your, from your peers, from people who are mentors and things, because they can see what's happening to you. Yeah. And seeking help is not a weakness. Yeah. It's not selfish to take a step back. And I think in some regards, working in the NHS, we're somewhat conditioned to be somewhat like martyrs in some way. Yeah. But the thing is, the reality is you can't burn yourself to keep the house warm.
Wow.
You can't.
Exactly.
You can't.
Wow. Yeah. You have to be brave, and you have to just speak out, even before seeking help, like at least just say, I'm not okay. Yeah. And this is not okay. Yeah. Because the expectations are perhaps unrealistic, wow. So, like how most of the healthcare people, professionals that I've spoken to, we always talk about patient care, how we can provide the best service, how we can do the best for our patients. So, the whole narrative is full of this kind of rhetoric. If I were to ask you to flip the script and say, what do you think that the patients and the community can do for the healthcare system so that it runs better? Like, what can your patients do so your life becomes a little bit easier? What would you say the answer to that would be? What are the first thoughts that come into your head?
That's a loaded question.
You needed some water for that.
I do. I really do. It's a very, very good question. I think I love the NHS. I don't think I would have been a doctor if I worked in a system such as in the US, for instance, where, before you going back to my background initially as an emergency medic, I would find it very, very difficult to work in a system where they would come in through the ED, and the first thing I have to ask is, do you have your
insurance?
Do you have your insurance? Do you have your paycheck? Exactly. Can you sign this particular form to say that you can pay things off? I would really, really struggle to work in a system such as that. I do believe to some extent that health is a right.
Yeah, I agree.
I think it is, I'm just very aware that, you know, I'm born and raised in a country where I've been very privileged to use the NHS myself.
Yeah.
And without to, you know, worry about, and same with my wider family and my friends, without having to worry about having to remortgage my house.
Right. Right.
Genuinely.
Right.
I mean, I've heard of horror stories. I've got relatives who work across the pond, and you know, over there, people have actually said no to ambulances when they're clearly having a heart attack because they just can't afford it. So
it's crazy.
I do believe in the NHS's ethos in that, you know, healthcare should be free to the point of care. But I will say the counterbalance to that is that people have a responsibility.
Yes.
So
I agree.
And that responsibility, it's a shared responsibility.
Yes.
Obviously, nobody's going to blame you if you get cancer or if you end up being diabetic.
Yeah.
But on the other hand, if you have got, say, for instance, let's say COPD, chronic obstructive pulmonary disease, and you continue to smoke and smoke and smoke and smoke, where is the responsibility there?
Yeah. Yeah.
Is that potentially a drain on resources otherwise? Although admittedly, and we can talk about these sort of social determinants of which lead to people end up, say, let's use smoking as an example, to lead to people smoking. And there are much wider issues at play here when it comes to patients' choices and when it comes to their healthcare.
Yeah.
And it's very well, I mean, I'm very, very well aware that, you know, if you're in a lower socioeconomic sort of sphere of living, you know, the cards are stacked against you. And I can really understand that. I can appreciate that to some extent. But I also believe there is a degree of ownership about your own health,
100%.
which is important.
100%.
And I think people, and it comes down to education, it comes down to health promotion, it comes down to perhaps even taxation.
Yeah. I mean, you know, and I think if I may add to that, you know, like what can the community do? I think a lot of people think NHS is free. It's not free because you're paying it through your taxes.
Absolutely.
Right? So one of my bugbears for from patients is the DNA rates. You know, so like you book your appointment and you actually don't turn up and not notifying the GP or the doctor service as well. So, you know, I did a little chat GPT research and basically in the UK, 1 in 20 appointments are missed each year, which amounts to 15 million missed appointment annually, costing the NHS £216 million.
Goodness.
Literally not turning up will cost the NHS. It all adds up.
Yeah.
And it costs the NHS £216 million. And for people who would have turned up, who needed an appointment, they don't get that appointment either. So I think a simplest intervention that people could do would be like either you turn up for your appointment or tell us that you're not going to turn up, you know? Like that alone could save near £250 million to the NHS.
I mean,
it's crazy.
I agree with that, but sometimes we need those DNAs to actually get our clinics running on time. It's a little secret here. I'm annoyed, but I'm also kind of grateful when the DNA happens. I kid. It's not good.
Once in a while.
It's not good. It's not good. No. You're right. And it's frustrating on my end as well. The number of times I've had I've had a letter from the radiology department or from specialties where I've done a very carefully crafted referral letter and then the patient doesn't turn up. Yeah. And you think, what was the point of that?
Yeah.
It's somewhat frustrating in that regard as well, coming from my side of things too. But I mean, I guess other sort of simple things as well. I guess maybe perhaps coming from a GP perspective, being sort of more health aware, I think.
Right.
You know? Right. I mean, there are a lot of simple things which can be done from a holistic point of view to help encourage, help promote your own health. Yeah. Such as, I mean, I think healthcare comes down to some very basic things. I think it's about exercising right, eating right, and, having good interpersonal relationships and things, keeping yourself occupied, keeping your mental health okay.
Yeah.
And I think sort of general sort of awareness of that might be something to help with the NHS going forward.
Yeah.
But again, I also understand that, you know, we are in a cost of living crisis. We are in the middle of, I think, mental health crises are much higher than they've ever been before, whether that's because of increased awareness or whether that's because of all the other wider socioeconomic issues at hand. But I think being somewhat aware of, you know, having some ownership over your health is really important, I think.
Fair. I mean, so, you know, medication is not always the answer.
No.
That's what we are trying to say.
Yeah.
And perhaps, you know, another thing that NHS can do is actually maybe increase spending towards prevention
100%.
Practices as opposed to, you know, just treating. You know, think about deprescribing as opposed to prescribing. You know, like we need to change, and we need to come out of more innovative ways. You know, like cholesterol, diabetes, blood pressure, stress, like whatever. Like the minute we say there's a pill for that, I think we've just started a lifelong, you know, circle. I mean, that's just my personal belief. And I mean, I'm a pharmacist. I should be pro medicine, but I'm like,
you're doing your job wrong.
I'm in the wrong profession. But, you know, it just made me think the way we are managing chronic conditions and the outcomes, what we see, it's just really made me think, are tablets the only answer? And you know, my feeling is it's not.
This podcast is not sponsored by AstraZeneca. Clearly not. No. I think the problem is, I'm just gonna take you back to my clinic, for instance. So I have 10 minutes. I have somebody who's very, very depressed.
Right.
I have a whole 10 minutes. I have a whole 10 minutes to actually get to the nuts and bolts of why they're depressed, what's going on, what's happening to them.
Yeah.
10 minutes is a very, very, very short period of time.
It's nothing.
It absolutely is nothing. It's a layover from back in the 80s when we had more GPs per patient capita, basically.
Yeah.
We had more hours in the day in terms of working as a GP. We knew our patient population. So it's a layer from a model which doesn't really work in modern times, unfortunately.
Yeah.
You have to remember, from the clinician side of things, I've got 10 minutes. What's the easiest thing for me to do? Sit there and actually talk through, employ a couple of cognitive behavioural therapy initiatives with the patient, which in itself realistically takes about half an hour to an hour.
Yeah.
Or to give a pill.
Right. Wow. Okay.
So
that's a decision you have to make.
Exactly.
Wow. So it is,
And you have to remember as well, you know, just going on the topic of mental health, for instance, you know, in the community, if I refer somebody for psychological therapies, at most they get about 6 sessions. Which is not really enough to even, you know, scrape the surface of what's actually going on with them.
No.
And so in some ways, pills, you know, I don't want to say we opt for pills out of convenience, but there is perhaps a certain element of that which happens as well. Makes sense. Perhaps on the patient side of things too, because, you know, going for, like, say, let's use cholesterol as an option. Going for a healthier diet involves for patients needing to meal prep, needing to actually look into the labels of their foods and things, looking at which ones have monosaturates versus transaturates. If there's a pill which can sort this out.
Yeah. I see what you're saying. Like, it's very interesting to think of it from that perspective that, you know, yes, pill is not the only answer, but look at all the other factors that play into, like, 10 minutes. I mean, I'm just trying to think, how do you even, diagnose somebody with depression and all of that stuff in just 10 minutes? Like, it's, I mean, what if I were to give you a magic wand, Krishni, and I say you can wave this, and, you know, this is the outcome you want, and based on this, the life of the GP is just going to become better. So if you were to wish for one thing that could make GP's life better, what would that be?
Time. I wish we had more time with our patients. And I think this is the reason why a lot of my colleagues and even my own practice, we're starting to employ some of the strategies for the strike, is what we're screaming out for. We need more time with our patients. We don't know our patients sometimes. Because 10 minutes to see a patient and then maybe follow them up even 2 weeks to 4 weeks down the line is just not enough. Patients are becoming more complicated. People are getting older. We've got a huge swath of wonderful investigations, wonderful medications, all sorts of therapies and things that we can do. And understandably, you know, and in a way it's good. Patients are aware of these things and they want more of these things.
Yeah.
I think what we need more than anything else in general practice is more time with our patients.
Right.
And actually getting to know and getting to the nuts and bolts of exactly what is ailing them and what's actually causing them problems.
Right.
And not having that and actually having that ongoing relationship with patients as well requires time.
Right.
So the 10-minute model, I don't think it really works in this modern age. I think we need longer times. I think we do need additional auxiliary staff as well to help aid us to do the job that we're doing, but not replace the job that we're doing.
Yeah.
And I think then in that way we would be allowed to do our job a little bit better.
Yeah. I think every healthcare professional will agree with you on that. Like we definitely need time. We actually need more time for with our patients. Fine. I mean, I think we are at the near end of the podcast. So but I have a very cool last section for you.
Oh.
So the last section is called Dose of Health.
Okay.
This is where I ask our guests to prescribe a dose of health. So what if I give you a blank prescription, but you cannot prescribe a medication? What else would you prescribe for better health? What would matter to you? It could be habit, it could be an advice, it could be an activity, but not medication. What would you prescribe for dose of health?
So, actually, I had no idea Abhishek had any idea that I did dancing. That was a bit of a shock. Someone's been snooping.
I follow you on Instagram.
I know. Oh my goodness. In all honesty, getting your body moving. Honestly. So one of the best things I ever did. So when I CCT'd, I was a little bit in a no man's land sort of feeling for myself, in that, okay, I've completed training, now what do I do? And I genuinely sat down and I thought, what do I really enjoy doing? And I also thought, conversely, I should practice what I preach when I tell patients to exercise and, you know, get the body moving, you know, all of these things. I thought, okay, I should really practice what I preach. Yeah. And one of the things I've never done this before in my life. I've never thought I would do it, but I thought, I'll start doing dance classes. Right. Honestly, one of the best things for your mental health and something which, you know, keeps me going. Yeah. Is doing dancing, and I'm absolutely atrocious at it, but I'm sure Abhishek can attest to that. But honestly,
quite the opposite.
He's being too kind.
You're very good.
But honestly, one of the best things I've ever done for myself was actually just getting the body moving, dancing, having a joke about with friends after class, singing afterwards. Honestly, movement really, I'm going to steal a quote from one of my friends. Sorry about this, Ari. Movement is medicine, honestly.
Wow. Movement is medicine. I think there is no better way to end this podcast rather than, than this particular line. Movement is medicine.
Copyrighted to my friend Ari, by the way. But it's true. It's really true.
I totally agree with you. Like, my parents, they have diabetes. They have history of, asthma and, overweight and all of that kind of stuff. And
you sound like one of my medical school exam questions, like, Asian family with diabetes.
Exactly.
What is the anyway?
It's not my family. I'm just describing a typical family, typical Indian family.
My family too, by the way.
And, I never, ever gave any importance to exercise or movement or whatever. And I really felt like, kind of like lying to people to saying, okay, you do this whilst I can just do whatever. And then once I started going to the gym and I just, my life just completely changed.
100%.
And now you just, you know, I just can't live without it. And touch wood, the health benefits, the mental health, the lack of stress, or no, not lack of stress, but ability to manage stress has just elevated to the next level.
I 100% agree with you. I mean, we met again in the same gym that we go to, but honestly, investing in, so I invested in a personal trainer this year, investing in actually going to the gym at least 2-3 times a week, along with dance, has been an absolute boon for myself. And I really strongly recommend, even if it's not dance, if it's something to keep your body moving, keep you occupied, it's one of the best things you can do. I mean, I started running initially, and there was a yogi in India who said, if you had a choice between doing any form of exercise or meditating, always choose exercising. Wow. Because exercising in itself is a form of meditation as well. I think people really, really underestimate the value of keeping the body moving.
Krishni, thank you so much for doing this.
Thank you.
It was incredible. It was incredible, and I'm sure people have learned loads from it. You know, and
I hope so.
And I'm sure people are going to be like, you know, perhaps look at GPs in a bit more empathetic way. That you know, behind the title, behind the GP surgery, there is a human being who's trying to help other human beings.
Absolutely,
you know?
absolutely.
So keep doing what you're doing. Keep dancing and keep moving your body. And movement is medicine. Brilliant. Thank you, Krishni.
Thank you for having me.